Right.
Okay, sir.
So participants also joining on the same link, right?
Right, sir.
So I can see only what 10 participants right now.
Right, sir.
Okay. So maybe I'll wait for 1 or 2 minutes and then we'll start.
Okay, sir.
All right, and I'll let you know when we start. So I'll start sharing the PowerPoint and then we can just start right away. So Sweta, you keep attendance of this. You keep an attendance of this meeting.
No, sir. I'm the moderator for today's session. Actually, Sangeeta deals with all the attendees and also.
Okay, she's looking at this. She's recording. Yeah. Okay, fine. Okay.
Right. She's the coordinator for this NNF session, sir. So she knows exactly.
Okay. You have the PPT with you, or should I share? I have.
No, sir. I don't have the PPT, sir.
All right, all right. I have it. I have it. So I'll share it on the screen and we'll start in a minute when I'm ready. Can you see the full screen?
Yes, sir. Perfectly visible, sir.
So I'm sorry, my PowerPoint just crashed. So,
Yeah, yes, so you can start, sir.
and I think I lost my link also. So I just restarted. I hope we should not have any further problems. I'm sharing my PPT. And so there goes. All right. So can you see the full, are you seeing the full screen or what are you seeing?
No, no, sir, it's in the presenter view, sir.
Okay.
Now
Now,
it's fine, sir.
all right. So yeah. So I'm going to be starting off here. Good evening, everyone. I'm Dr. Somsekhar Nimbarkar, Professor and Head of Department of Neonatology at Pramukh Swami Medical College in Karamsad. I can see that there are some 18 people who have joined, and I can see, I think, one from my own college, and everyone else is from the Western zone. So let's start. Today we'll be discussing post-resuscitative management of asphyxiated neonate, and the second point is neonatal seizures. You can ask me questions in between also. Maybe if you put the question in the chat, I will try and answer it. Okay, so this is the first topic that we're going to be dealing with. It's the second most important cause of neonatal death after infections and accounts for around 30% of mortality worldwide. As you can see that there's a in the picture, there's a baby who is being bagged with a bag and mask. Now, in terms of newer guidelines, ideally we should be using a T-piece resuscitator, and that's the preferred resuscitation modality which is there, rather than the bag and mask. So that's as far as the newer guidelines are concerned. But for most practical purposes, we are going to be using only this. The reason is because this is most commonly available and does not require any backup pressurized gas flow. So the learning objective is so how to go about initial stabilization and management of an asphyxiated neonate, what monitoring needs to be done, and look at what are the poor prognostic factors in asphyxia. So that is what we are going to be looking at. Now, there are various definitions of asphyxia, and as you can see, the one is gasping or ineffective breathing or lack of breathing at 1 minute of life. That is usually when you would want to start your bag and mask ventilation. And it's another thing that if a baby has required a positive pressure ventilation for more than a minute, and the Avgar score is less than 3 at 5 minutes or longer than that. There are many multiple definitions of asphyxia, as you can see, and on the left hand side, this is what is called as a Southeast Asia Regional Neonatal Perinatal Database working definition. So for when you say for extramural babies, for babies who have come from outside the hospital, and we are looking at whether there was slow gasping, breathing at 1 minute of life, and if it is severe birth asphyxia, if there was no breathing at 1 minute of life. This is the definition from the SEER and NPD database. For babies who are born in the same hospital, if the Apgar score is less than 7 at 1 minute of age, it's birth asphyxia. And if the Apgar score is between 4 to 6 at 1 minute of age, it is moderate. And if it is less than 3, it is severe. The AAP and the ACOG definitions are relatively more complicated. Talks about umbilical cord pH of less than 7 or so, and Apgar scores which are almost similar to what we are seeing in severe birth asphyxia in the intramural babies. And again, there needs to be neurological manifestations or multisystem organ dysfunction. The WHO definition is the most simplest and easy to follow. Failure to initiate or sustain and sustain breathing. So this is something which keeps it very simple. Uh, Something called as post-resuscitative care. If you look at the algorithm, this talks about a baby gasping or whatever, or apnea, and there is labored breathing also. If there is yes, then you kind of do position and give positive pressure ventilation, or you can consider CPAP. And if a baby has received TPV over here, then the baby requires what is called as observational care. Otherwise, if it gets resuscitation, then it goes to what is called as post resuscitation care. So if there is PPV, which is there. All right. So this is something which is commonly followed. So we need to also do clinical monitoring and complications. So look at assessing the severity of the asphyxia. Why we need to assess the severity? Because our treatment kind of depends upon it. What clinical monitoring we need to do to assess the severity and how the baby is progressing. And we'll discuss a little bit about how we can minimize the damage and newer modalities for minimizing the damage, and what investigations are commonly done, and what how can we prognosticate such babies. This is a baby who is hypotonic, who's not breathing, and this is commonly babies who have suffered birth asphyxia. And birth asphyxia has adverse effects. So basically, it's cutting off oxygen to the organs of the body, and that includes the brain, kidney, heart, lungs, GI tract, everywhere. So it's in many ways a multi-organ dysfunction, and depending upon how much and how many organs are affected in what severity, your clinical manifestations would occur. So if the brain is damaged severely, then you would have seizures, there will be lethargy, irregular respiration, hypotonia, and coma. So all of this would indicate CNS involvement. Uh, Damage to the kidneys would sometimes have you an AKI like picture. Damage to the GI means many times peristalsis is reduced. So in many ways, even lungs also do get damaged with asphyxia. So the damage to the organs of the body is tremendous, and across all organ systems per se. In terms of preterm versus term gestation, the damage would definitely vary because you would have the growth of the brain, of the preterm brain, is not as much as the term gestation, and you would have parasagittal cerebral injury distribution in the term brain per se. Okay, so in as I talked about renal injury, you can have acute kidney injury, you can have hematological manifestations, you can have shock because the myocardium also suffers from asphyxia, and the respiratory damage may also need to say that there is need for respiratory support per se, and feed intolerance also can occur. Now, how do you grade the severity of the birth asphyxia? There are various scores which are used for grading the severity. One is commonly that needs to be used, or commonly uses the Levin's grading, and it needs to be done every 8 hours or so. It classifies the encephalopathy into mild, moderate, and severe based on what you are assessing. And this is relatively simple to assess. Consciousness, tone, seizures present or not, and the suck on the finger, and respiration. So as you can see, mild encephalopathy, you have hypotonia, which is there, and but the baby is breathing spontaneously. There are no seizures, and there is a poor sucking, and the baby is irritable. But in moderate, you would have seizures, which is something which is very specific to moderate encephalopathy gradings in many other gradings also, and you will have coma in severe encephalopathy. So this Levin's grading has to be done every 8 hours when the baby is admitted in the NICU. Right. So that's that. The other score is the Thompson score, where you have a little bit more parameters that you're going to be assessing. So the tone, level of consciousness, seizures. So posture gets added here, Moro gets added here, grasp gets added here. Okay, and the Fontanelle also gets added here. So these are additional scores as compared to the Levin score. What is interesting is that you can have very poor scores, which is the maximum score of 22. And but if you score more than 15 or more, it gives you a very good positive predictive value of 92% and negative predictive value of 82%. So these are good predictors, and so doing the Thompson scoring also would give you an indication as to what will happen to these babies in terms of prognostication. It's pretty good. So it gives you all these predictors for abnormal outcomes at 12 months of age. So at birth, you can score a baby, and you can kind of predict what can happen to the baby at 1 year of age. Uh, this is the one which is most commonly used, and has been used by most places, most institutions, where you look at level of consciousness, neuromuscular control, complex reflexes, autonomic function, seizures, and EEG finding. Again, you have this classification to mild, moderate, and severe. And with moderate, commonly it is seizures, which is present in that particular classification. Now, when you are presented with a baby who has birth asphyxia, this has been one of the most interesting questions of how to manage a baby of birth asphyxia. Very interesting research has happened in the last 20-25 years, with some kind of definitive therapy being kind of introduced, or the world kind of shifted to in 2007 to 2010, which you can see down below, which is therapeutic hypothermia. So therapeutic hypothermia is kind of a definitive therapy for birth asphyxia, moderate to severe birth asphyxia, and it can be used where if facility is available. Now, if that is not available, then you would use supportive care for to maintain temperature, perfusion, respiration, and metabolic status for all patients that come to you. Okay, so uh, to maintain temperature between 36.5 and 37.5 degrees centigrade, it should be our goal. Airway should be clear, and do remember that many of these babies are can be hypotonic even with mild to moderate asphyxia, and if the airway is not maintained properly, if the airway gets skinned because of hyperflexion or extension, then that itself can cause the baby to have respiratory issues. Respiratory support if needed, and the target SpO2 is 91 to 95, and we should be able to maintain blood pressure in the normal range. Uh, if as severe asphyxia is there, you would want to start with IV fluids, because remember, the GI tract is also affected by asphyxia, and there can be fluid intolerance. And once meconium is passed and the abdomen is soft, you can start oral feeds. Uh, Many of these babies can have issues with metabolic dysfunction, such as hypoglycemia, or hypocalcemia, and so all of these parameters should be checked for and managed accordingly. And we'll come to management of seizures in detail, especially in the second half of the lecture. But that's something which commonly also happens in birth asphyxia. So what else do we monitor? So we monitor the vitals. So baby would have an ECG leads placed, uh, uh, non-invasive blood BP monitoring, and if the baby is severe, then invasive BP monitoring. Check for shock using capillary refilling time. Check for respiratory distress monitoring. Urine output, because you can have AKI in such babies. So measuring the diaper weight on a regular basis and see how much urine is passed. Abdominal gut monitoring. This tells you whether the GI tract is functioning well or not, if it is tense. Glucose monitoring, as I mentioned, and of course, neurologic examination of the baby using the scoring systems that I mentioned earlier in the initial phase of the management. So Levine staging, as I said, 8 hourly, CVS, blood pressure, heart rate, NIBP, NIBP, SpO2, peripheral pulses, and respiratory system. So the slide says Downey Silverman scoring every 2 to 3 hours. So Downey's score is actually Downey Vidyasagar score. So Vidyasagar was the professor and Downey was the student, and they got a grant from NIH in the 1960s in the US, and they developed this score, which is as a part of a research project. So somehow, in many ways, Dr. Vidyasagar's name is not mentioned, and only Downey's score is mentioned, which I don't find to be pleasant at all. So AG monitoring again, urine output needs to be kept at more than 1 ml per kg per hour. And as I said earlier, management of sugars and seizures. Now, this is a interesting graph that we need to look at. As you can see on the left-hand side, there is hypoxia or ischemia, which the baby has. Now, this onset of hypoxia or ischemia can begin in utero or can begin during delivery or sometime before delivery. So we really don't know when this has happened. This leads to primary neuronal death, commonly in the first few minutes or hours of life, and then after a brief period of about 6 hours, there is delayed neuronal death. Now, why is this important? Because this actually gives you a gap of a few hours between primary neuronal death and delayed neuronal death. So within these 6 hours, if you're able to do something to the brain that ensures that the brain is not damaged further, and in many ways you're preventing delayed neuronal death, you would be doing what is called as, in many ways, a neuroprotective therapy. And so hypothermia, keeping the baby in hypothermia, is going to save the neurons in the brain. So this is something that we need to understand. This is a slightly complicated graph, and we really may not want to go into detail of this, but it actually tells you at what places does hypothermia act. Okay, so what is the process of the damage that basically happens? So basically, we have neurons depolarizing, release of excitatory factors which act on receptors and tend to cause brain damage. So there is intracellular enzymes which are released outside. There is influx of calcium, which causes death of neurons, and so on and so forth. Hypothermia acts on these three places, as you can see on the screen. Uh, and there are other factors which have been tried and are in research, which where they might be still helpful. But all said and done, therapeutic hypothermia is the only known therapy as of now, which is known to be neuroprotective in birth asphyxia. Okay, and avoiding 100% oxygen is also something which we should always do. Now, this is a systematic review which looked at cooling for newborns with hypoxic ischemic encephalopathy. Now, this looked at around 11 RCDs, but there were three major RCDs which kind of directed the outcome of this systematic review. The NICHD one, which was published in 2007. There's another European trial which was published in, I think, 2009, and there was a trial from UK which was published around the same in 2007 itself. So if you look, and so this systematic review looked at the combined outcome of mortality or major neurodevelopmental disability, and it shows numbers needed to treat for benefit as 7. Okay, and for mortality, the numbers needed to treat for benefit is 11, and for major neurodevelopmental disability, again, it shows a relative risk of 0.77. In general, these are very good numbers, which means that therapeutic hypothermia is a very good therapy to ensure that you prevent the brain damage in patients who are born with moderate to severe hypoxic ischemic encephalopathy. So here it becomes important to understand that we are trying to treat moderate to severe HIE only. We are not trying to treat mild HIE. So mild HIE cooling is not indicated. So how do you determine whether it's mild HIE? By doing a scoring system. So having this Levine scoring system or the Thompson scoring system to ensure that you're looking at to know that you're managing a moderate to severe HIE, what kind of HIE it is, will lead you to uh, cooling the baby. Now, most of these trials were actually done in developed countries. And so what happened is there was this a study which was started in August 2015 and ended up around, I think, August in 2021 or so, where it is also known as the HELIX trial. So hypothermia for encephalopathy in low and middle income countries. Now, when you do therapeutic hypothermia, in the developed world, you are using servo-controlled cooling. That means the temperature of the baby is maintained at around 33.5 degrees centigrade, the entire body. So there were three trials. One was the cool cap trial, or the trial which only cooled the brain, and there was the whole body cooling trial, which I mentioned is the NICHD trial, where the entire body was cooled. But in all of these trials, The endpoints generally were at 33.5 degrees centigrade. The full baby was cooled generally for 3 days. So within 6 hours of life, the baby is cooled for 3 days, around 72 hours. There is a rapid cooling within 1 hour roughly. The baby is cooled, kept cool at 33.5 degrees centigrade, and then there is slow rewarming. Rapid rewarming can cause seizures, and slow cooling does not have a lot of benefit. And the most important point about therapeutic hypothermia is that the baby's temperature should be maintained at 33.5 degrees centigrade with not much variation. So it should not go below 33 and should not go above 34 degrees centigrade. If there is wide variation in the temperature when the baby is being cooled in the 72-hour period, it does not give you the same therapeutic benefit. Hence, it is important to have servo control systems. In India, there were many non-servo control systems which are used, and which many people still continue to use. Now, based upon, and most of this were being used between 2008-9 to 2020 or so. So this particular uh, Helix trial was conducted in India, in some colleges across India, and this particular trial did not show a benefit in developed country settings. So I think in 2021 there's a lot of, when this study got published, there's a lot of discussion around this particular trial, and National Neurology Forum came out with a position statement because that particular trial suggested that therapeutic cooling should not be done in Indian settings. A lot of people in India felt that the trial was conducted in settings which did not have, or which were not conducive to therapeutic hypothermia, and hence felt that the results of the trial cannot be applied to everyone in India. So NNF had this position statement. It said that the baby is more than 36 weeks of gestation, less than 6 hours of age, and with admission temperature between 36 to 37.4 degrees centigrade, and if they have the criteria for birth asphyxia, as you can see on the screen, pH of less than 7, or basic excess of more than 16, on ABG done within 1 hour of life, a ABGA score of less than 5 at 10 minutes, or at least 10 minutes of positive pressure ventilation, history of acute perinatal event, and evidence of moderate or severe encephalopathy. So if these criteria were fulfilled, then the NNF guidelines suggest that we can, and if you're able to provide good therapeutic hypothermia, you should go ahead and provide therapeutic hypothermia. Now, what is the role of imaging in HI? Now, there are various imaging modalities. Of course, X-rays are not done, but for this particular aspect of birth asphyxia, uh, two common things which you can commonly use is actually ultrasound sonography and MRI. CT scan is not done because it has a lot of radiation and it may not provide so much information. But MRI gives you very good information on how much damage is there to the brain. And so it's the best modality, and it also tells you the prognosis, like what can happen to this baby in the future. So there are different kinds of MRIs. So diffusion weighted MRI picks up abnormalities between 24 to 48 hours after birth, and conventional MRI shows abnormalities in the first 3 to 4 days, and it is more pronounced later during the first week. One should remember that many of these MRI abnormalities disappear after a few days. Hence, the timing of doing the MRI has to be as shown on the slides, but and the kind of MRI that you do. It has been shown that if there is an altered signal at the posterior limb of the internal capsule, and abnormalities of the thalamus and basal ganglia in term infants, or if of white and gray matter at term equivalent to age in preterm infants, these are both strong predictors for poor neurodevelopmental outcome in these patients who received birth asphyxia. So in many ways, MRI is like an astrologer for babies with birth asphyxia, which can tell you what will happen to this baby in the future. Okay, there are other investigations that you can do, but this depend upon if there is a need for it. So you can do a sepsis screen, blood culture, if you think antibiotics are required, or if the baby is showing signs of sepsis, there is some history of sepsis, or if you want to look for other stuff. So, but this is again depending upon the clinical manifestations which are present, and these are not done for birth asphyxia per se. I mentioned ultrasound. On ultrasound you can get small compressed ventricles or intraventricular hemorrhage. CT scan commonly is not done, and it's mainly you end up with doing MRI and EEG. So EEG is something which you can see over here. So you have your what is continuous EEG monitoring or CEEG, and you have amplitude integrated EEG. Now, most centers do not have amplitude integrated EEG, but it is something which is very useful for monitoring patients of birth asphyxia. In I mentioned trials in the early in 2000 to 2007, etc. Some of the trials used one of the trials was the NICHD trial that was published from US, and the UK trial was called as the Toby trial. The Toby trial used EEG, I think, for uh, allocating whether this baby should receive therapeutic hypothermia or not. So EEG is not essential to decide whether the baby should receive therapeutic hypothermia, but can be a good modality to monitor such patients. Okay. Now about preventing asphyxia, what can be done? So one is, I think, babies who have complications during labor or have a high risk should be delivered in centers where good resuscitation is available, and preferably you might want to do an LSS if the baby is at severe risk, and managing timely referral, and ensuring that the baby is delivered in a area where there are good facilities. There are various preterm brain protection. You have this interventions that you can see. These are basically uh, when you don't want when you want to ensure that these are the modalities which can prevent preterm brain damage. 19 steroids given to all babies below 34 weeks of gestation, to all mothers who are likely to deliver between 24 to 34 weeks of gestation, is known very well. It's one of the most impressive interventions which has been known to prevent to decrease IVH, decrease developmental delay, and decrease CP in the babies. Magnesium sulfate given in labor to mothers actually improves or decreases CP in babies born preterm. Delayed cord clamping also reduces IVH and gross motor dysfunction. Gentle ventilation is also known to prevent uh, PVL and IVH, periventricular accumulation, intraventricular hemorrhage. Now, when I say gentle ventilation, when you have a baby which is born and which is not breathing, most of us use bag and mask, and in our anxiety to ensure that the baby breathes, we tend to bag the baby vigorously, which is actually not good. You would want the chest to expand just enough to have a good heart rate. So you really don't want to see the chest expanding in such a big manner, but basically a little bit so that you have just enough chest expansion to cause a rise in heart rate. And this gentle ventilation that you do at birth should be followed by gentle ventilation when you do your ventilation of babies. So golden hour strategies usually are delivery at the tertiary care hospital, delayed cord clamping, and maintenance of normal temperature and improving admission temperature. The third thing that you can see, improving admission temperature becomes very important. Uh, when a baby gets admitted to the NICU, if the baby's temperature at admission is less than 36 degrees centigrade, it is an independent risk factor for mortality of a newborn baby, which is not really good. When we talk about delivery room CPAP for preterm neonates, it's again gentle ventilation. You're trying to ensure that the alveoli, when babies get delivery room CPAP, the alveoli are kept expanded. They remain expanded for with there is no collapse and expansion of the alveoli. They remain expanded. This ensures that the surfactant which is there is preserved for a longer period of time, and closure, or what do you say, the alveoli collapsing and expanding causes what is called as atelectator trauma, and does impact not only the lungs but tissues elsewhere too. And optimal use of oxygen means that you would prefer to use room air in most babies, And if the baby is preterm, you might want to start with 30% FiO2 and monitor the saturation and track the saturation to either increase the oxygen or decrease the oxygen. So ensuring that the baby is received appropriate amount of oxygen. There are studies, these are not RCTs, but there are studies which show that even in term babies, even for a brief period of time, like 3 minutes or 4 minutes, if there is exposure to 100% oxygen, it has been linked to cancers in adolescent life. So oxygen is a drug and has to be used carefully in even in newborn babies. What are the poor prognostic factors? What are the reasons why babies might have poor outcomes in birth asphyxia? If the baby receives positive pressure ventilation for 5 minutes or longer, if the onset of seizure is within 12 hours of delivery, if the seizures are not being able to be controlled by phenobarbital and phenytoin and require more drugs, uh, in Levin score, if it is severe HIE, or as we saw in the slide earlier, if in the Thompson score, if the score is more than 15, all of this indicate that there is poor prognostic factors. Uh, One of the commonest things that many of us see of babies. So what happens is many times babies come with birth asphyxia. They come late. They come once seizures start at 7, 8 hours. So there's no chance of of therapeutic hypothermia. And because babies are seizing, you tend to give anticonvulsants. Baby might go into arrest or may have respiratory depression. You ventilate the baby. Baby remains on a ventilator for 3 to 4 days, and then you extubate the baby. But you realize that even at the end of 1 week, this baby is not able to take any feeds, and you have to continue to give gavage feeding. So this is in many ways an indication that this baby, 1 week after birth, is still not able to establish oral feeds, and is a sure shot indication that this baby would have poor neurodevelopmental development later on in life. So all babies who suffer perinatal asphyxia have to be followed up regularly, not only for growth but for checking whether there is the outcomes long term whether the baby is developing normally in terms of neurodevelopment. Why is it important? Because you can offer therapy, you can offer physiotherapy, you can offer early stimulation to many of these babies to ensure that whatever development is possible is achieved. You may not be able to reverse it, but at least you can achieve whatever development is possible if these babies are tracked on a regular basis. So what have we learned so far as far as birth asphyxia is concerned? So HI is actually very complex. We don't know when it begins. It begins in utero or during the delivery period. There are various things that can contribute to birth asphyxia. The best therapy is therapeutic hypothermia if you're able to give it in the best possible fashion. But if you're not able to do that, then it's important to have supportive management. And the pathophysiology differs in terms of preterm and term gestation, and hence we do not offer in preterm babies therapeutic hypothermia. Coming to the next topic, so I can see about 33 people or 34 people in the lecture. If anyone wants to ask a question, you can put a chat, or I think that would be good. So I can give a break of a minute or so. We are at 8:42. We have significant number of slides still to go, and I'm also tired, so maybe I'll just take a gulp of water. I can see a chat question. Let me check. What to do for weak cry? So good question. So babies are actually one is cessation of cry after initial crying. One is we have to establish whether the baby is breathing properly, adequately. There is no gasping breathing. Breathing is regular. If breathing is regular and the baby is not crying, it is fine. All right. Now, it has been seen that if the baby cries and cries loudly, it tends to establish a bigger FRC in the lungs. Its crying is actually good, but if the baby has not cried very much but is breathing regularly, then we don't need to do anything. But if the baby has cried initially, and this often happens in babies who are born preterm, maybe just late preterm, they will cry, and then they will be, because many times these babies would have been born of CS or something like that, and they would have received magnesium sulfate. There might be an initial cry, and then there will be a weak cry, and their breathing might be depressed. So in these cases, you would want to resuscitate the baby as if the baby is having is not breathing. So, but the most important part is to know whether the baby is breathing or not. And second, what's the heart rate? So if the heart rate is low, uh, then definitely the baby is not going to be breathing well. Then you would probably go ahead and do bag and mask ventilation. I suppose that was that is understood. Going to next to neonatal seizures. So neonatal seizures is basically an alteration in the neurologic function of a neonate, motor behavior or autonomic function. And whenever it happens in the newborn period, it is an emergency. We look at how to identify neonatal seizures, various causes of neonatal seizures, what do we do, and whether to continue anticonvulsants for a long period of time. So I will play you a video. I hope you can see the video. You can look at the mouth. Okay, so see what's happening to the mouth. This is the baby is not trying to feed, but this is kind of what used to be originally described as a subtle seizure. Okay, so this baby is having continuous, regular rhythmic movements, and you can see it started in the mouth, then it went on to the limbs. All right, and you can see the seizures in the eyes, again rhythmic. Okay, so this is another seizure which is happening. If you had an EEG in place, you would find electrical activity in the brain, which is showing this, what do you say, spasmodic activity. You can see the right arm focal. Yes, all seizures begin focally and then progress peripherally. All right. Now you can see that both the arms and the legs also happen. Okay. The heart rate has gone up, as you can see. So you'll have changes in the heart rate, etc. Next. So very interestingly, there was an update in 2020 where they looked at change in the classification. So the don't go by books which are written before 2020 or before 20. Yeah, so those would have an older classification of seizures. So there's a newer classification of seizures. So if you look at the 2011 guidelines, as you can see in the bottom of the slide, clinically apparent seizures more than 3 minutes or brief serial seizures to be taken as significant. That was the earlier guideline. Now, an electrographic event with pattern characterized by sudden repetitive evolving stereotype waveforms at beginning and end. So what you can see on the EEG, the duration is not defined, but has to be sufficient to show that there is an evolution in frequency and morphology of the discharges, and it needs to be long enough to allow recognition of onset, evolution, and resolution of an abnormal discharge. So it's not defined per se, and if it is more than 10 seconds, it might show better inter-rater availability, but you can even consider shorter serial events. So as you can see, these are the various causes of seizures. The biggest size one is HIE, which we discussed in the previous 35 minutes or so. Other causes are infectious, vascular. Vascular is actually probably the second most. Strokes are probably the second most common cause of seizures. Then infectious, metabolic, genetic, and brain malformation, and so on and so forth. Okay, so how do you classify neonatal seizures? So neonatal seizures for us we should be applicable in all healthcare settings. Everyone should be able to accept it. The classification should allow you to kind of uh, dictate what treatment can be done, and EEG should be also be used for classification of neonatal seizures. You can have various things. You can have either clinical only, or electric clinical, or electrographic only. So you can have clinical only seizures, which you can see actually, or electroclinical seizures where you can see the clinical signs as long as which is coupled with the EEG finding which you are recording at the same time only, or electrographic seizure. So this is when if you have access to EEGs or AEGs, what will happen is you can see a seizure in the EEG, but you may not see any clinical signs. So even these seizures need to be ideally controlled because they have been seen to show do damage to the brain, even if there are only electroencephalographic seizures. So if there is an EEG seizure but there is no physical seizure which you can see, that means it does not mean that has to be neglected. Even that has to be ideally treated. So look at this classification. Look at the right side. Newborns have been, most of them have a focal onset, and so there is the division into focal or generalized is not really useful. The newer classification which is there is motor on non-motor classification. So non-motor basically means that there is a autonomic signs which are there. So there is a change in heart rate, blood pressure, etc., or there is a change in behavior which might have happened. So these are non-motor signs. Motor signs are when you have automatisms, clonics, epileptic spasms, myoclonic or tonic seizures. So these are motor spasms. Sequential when you might have non-motor followed by motor, or you can have unclassified seizures. So when you have when a baby is critically ill or there is clinical suspicion such as in HIE, then the baby then you might have access to video EEG or AEG, which most of us don't have. We have in our hospital in the last few months we have got AEG, but most places don't have it. So that will tell you whether there are non-seizure episodes or there is an electroencephalographic seizures. So you can have seizures with EEG correlates if you have an EEG, or if you don't have an EEG, then you can have only clinical seizures. Okay, so that is how you would kind of classify. So these are the various types of seizures, subtle seizures, which we saw in the video earlier. Blinking, eye deviation, movements of mouth or tongue. Okay, purposeless movements of the limb. And then you have clonic, tonic, and myoclonic seizure. This is kind of a definition that have been used for quite some time. Then you can describe your automatisms: unilateral, bilateral, symmetric, bilateral, asymmetric, focal, multifocal, bilateral, so on and so forth. This is basically to allow you to describe the seizure when the motor seizures happen in the neonatal period. We'll kind of not go into detail in this, but this is kind of fairly simple and can be used to describe your seizures. So you have epileptic spasms, clonic seizures, tonic seizures, myoclonic seizures, and automatisms which are there. There are some epilepsy syndromes which can happen, which are often which require genetic testing and video EEG monitoring, etc. So those are epileptic syndromes which you might want to consider sometimes. This is what we are commonly faced with. What if EEG is not available? Then observation by experienced personnel is more than sufficient. So you can see in the red box which is there, if there is no EEG, and if experienced clinician says that there is focal tonic or focal tonic seizure, then this is more or less a diagnosis of seizure. Okay. If those two are not there, then it is a possibility of seizure does exist. Okay. And if there is no experienced personnel, then you really don't have any way to diagnose a seizure. As you can see, if you have AEG available and it is not correlating seizure, then you can't really say that there is a seizure. Then, but if it is correlating, then again it is like a probable diagnosis of seizure. I would like to draw your attention to the fact that when there is AEG correlate or there is observed by experienced personnel, in both places you have a probable diagnosis of seizure. It's only when you have a continuous EEG, then you have a gold standard diagnosis, which most of us don't have. All right, so some of us might have AEG, many of us don't have. So we are left with the red box which you see, which is observation by experienced personnel. One of the commonest questions that is asked is what is the difference between seizure and jitteriness? And this is a common clinical question that is asked in vivas. Very important is you can have jitteriness which are stimulus sensitive, means you can induce jitteriness. This is something very, very interesting, very important. Abnormal eye or gaze movements are present in seizure, not present in jitteriness. So these are kind of either or. So this, okay. Predominant movement is clonic jerks, and here it is tremors. You can stop jitteriness. You can't stop seizures. There are autonomic changes. So just like eye changes are there here, there are autonomic changes. No eye changes here. There are no autonomic changes in jitteriness. And neurological examination may be normal in seizure and jitteriness. Okay, in between episodes. And EEG also may be normal in seizure and will be normal in jitteriness. So if it is abnormal, either the neurological examination or EEG, then it would suggest that there is a seizure. Going next. So treatment, most commonly as we manage our patients, we look at temperature, airway, breathing, and circulation, and this is our common steps for most of our clinical emergencies. Very important because many of the seizures that we see in newborn period commonly come from metabolic abnormalities, either sugars or calcium, and hence one of our first things that we do when we have seizures is we measure our sugars and our calcium. So if the sugar is less than 45 milligram percent, then you would give a bolus of 10% dextrose of 2 ml per kg, and then start a infusion with a glucose infusion rate of 6 to 8 milligram per kg per minute. So this is the things that we need to do immediately. If the sugar is normal, then you would want to check for serum calcium levels and give calcium gluconate. One of the things that we used to do 30 years back, we used to add calcium to maintenance heavy fluid. We do not do any longer, and if some by chance somebody is still doing it, we should not be doing it. All right, so adding calcium to IV fluids is not done. We used to do it many years back. We don't do it any longer. Okay. If seizures persist even after managing or correction of hypoglycemia and hypocalcemia, then you would want to start with anticonvulsant drugs. Now, this has been again an interesting field of study in the last 7, 8 years or 10 years or so. Uh, New and everyone likes new things, new phones, new computers, and uh, so uh, and also new drugs or new antibiotics. So levetiracetam was one new drug which was frequently being used in seizures in children and in neonates. And so there was a study sometime back published which compared levetiracetam with phenobarbital, and it kind of proved quite conclusively that phenobarbital is much more useful than levetiracetam. So the point what I want to make is, as of now, even now, phenobarbital continues to remain as a first-line anticonvulsant. So you would want to give 20 milligram per kg IV infusion over 20 minutes. Giving this fast can cause respiratory depression, and you might then need to intubate the baby. So you don't want to do that. So try and give it as an infusion over 20 minutes. Very important point is if the baby has no more seizure, then you don't need to give any more anticonvulsant. So this is something which has changed. Previously, we used to give Phenobarb, and then the baby used to go on maintenance Phenobarb. So we don't do it any longer. So if the convergence persists, then can give subsequent doses of 5 milligram per kg of Phenobarb to 40 milligram per kg. Okay, and then start maintenance. You can start with the second line anticonvulsant drug if it is not controlled. So you could use either phosphonate or phenytoin, again slowly over 20 minutes, and then start maintenance dose of phenytoin. Uh, can anyone tell me why phenytoin should not be mixed with dextrose? If anyone is attentive and wants to answer the question in the chat. Okay, so you can have crystals formed when if you mix it with dextrose. So you don't never really mix it with dextrose or given a line. Yeah, correct. Precipitate that happens. So you do not give in a line which is having dextrose. You would want to mix it with saline and ensure that you give it in a line where there is saline and not dextrose. If seizures persist, then you can use lorazepam. Many years back, we used to use diazepam. We don't use it any longer. And midazolam can be used if lorazepam is not available. So very interesting question. Which is the preferred second line for newborns with seizures? So in 2011, we used to talk about benzodiazepine, phenobarbital, or lidocaine. Now we have phenytoin, levetiracetam, midazolam, or lidocaine. Okay, so that's how things have changed slightly. This is the chart I think which you would have got on how to manage neonatal seizures. We are close to almost 1 hour of the lecture, so I would not really go into detail, but just remember glucose, as you can see here, then calcium, Okay, then if seizures are controlled, then do not start maintenance. So whatever I've spoken in the earlier few slides, it is given in one chart. Then if you give phenobarbital, then you seizures are controlled, you start maintenance. If you're not seizures are still persisting, then you start phenytoin, continue phenobarbital and phenytoin, lorazepam, and then if still with lorazepam it is not there, then send to a higher center. So in one chart you can make out what is kind of happening. So what is the duration of anticonvulsant therapy? Now, one is if it is because of a metabolic problem where you have detected hypoglycemia or hypocalcemia and you have given calcium or glucose and the seizures are stopped, it is possible that you might have started given phenobarbital also. So even if you have started phenobarbital by mistake or given by mistake, you do not continue it any longer. So there is no need to. Uh, so even if you have started an infusion, you can stop the infusion right away. So anticonvulsants drugs have no role when there is a metabolic problem that you have detected and managed. Now, if you are given phenobarbital, as we mentioned earlier, no maintenance therapy. Multiple doses of phenobarbital, then you would start maintenance phenobarbital. But again here, if the baby does not have convergence for 48 hours, then you would stop phenobarbital. If there were multiple anticonvulsant drugs which are there, then you would stop phenytoin after 48 hours of seizure-free period, continue phenobarbital, and then assess neurological status. If the neurological status is normal, then you stop phenobarbital. If it is abnormal, then you may continue oral maintenance phenobarbital. If at discharge, if the neurological examination is abnormal, then you may want to continue maintenance, which also means that if at discharge neurological examination is normal, then you would stop phenobarbital. Okay, and at 1 month of age, if neurological status is normal, stop phenobarbital, and if abnormal, then you may continue phenobarbital therapy. If neurological examination is abnormal after 1 month, then you would need to refer to a neurologist. The general impression or general learning from this particular slide is that as much as possible, you would try and stop anticonvulsant therapy at the first possible, what do you say, reason or excuse that you get. Previously, 30 years back, 40 years back, I remember babies being on phenobarbital for 1 month, 2 months, 3 months, 4 months, despite being normal. We actually would have ended up causing uh, apoptosis in the brain because all anticonvulsant drugs do have uh, side effects in terms of damaging neurons. So the current approach suggests that as if there are no seizures occurring either during admission in the ICU or at discharge or any time after discharge, then the first thing that you do is you stop your anticonvulsant drugs. Okay, so if newborn has seizures and is controlled on current anti-epileptic drug treatment, when should the medication be discontinued? So we are kind of answered. Following suggestion and without evidence of any neonatal onset epilepsy, you would stop anti-seizure medications before discharge, regardless of MRI or EEG findings. So this is very important. Okay. Previously, we used to worry about EEG findings. Here, whether EEG or MRI shows abnormality, it does not matter. You can stop. So uh, there's no real benefit of doing any EEG. I remember many times 30 years back, we used to all babies who had birth asphyxia had seizures underwent EEGs at 3 months of age or 5 months of age, and then we used to decide if there was EEG was abnormal, which often it was, because many people would not know how to read EEGs of very small babies, and the babies that continued to remain on phenobarbital. So that's something good now that we don't really have to bother about EEG or MRI if the baby does not have seizures and no features of neonatal onset epilepsy. So age is really not very important so much as far as managing babies are considered. Continuous EEG is much better than amplitude integrated EEG. As you can see here in the systematic review, it is a fairly okay role in diagnosing what do you say seizures, but not much. So conventional EEG remains the gold standard. So, coming to the final slide, all neonatal seizures are focal in onset, and nomenclature is based on motor and non-motor terminology. EEG would tell you a diagnosis, but does not really help you in stopping your drug therapy in many ways. And phenobarbital still remains the oldest gold drug of choice. And levetiracetam it comes as a close second line along with phenytoin and fosphenytoin. And as I said a few minutes earlier, the earlier you stop the anti-epileptics, the better it is. There's no need to go continue anti-epileptic therapy for 3 months, 6 months, etc. Even in pediatric epilepsy syndromes, uh, the trend is to give a relatively short duration of anti-epileptic drugs. That brings me to my final slide. That is thank you. And I would answer any questions if they are there. So I can see that there are very few people who are there. Two people from my department, from my college, Parth and Hardi, I can see. Okay, then, if there are no questions, I think Kalpesh I can see. Uh, Ria I can see. So four people from my department. Nice. So Shweta, if you are there, we can kind of stop the presentation.
Yes, sir. This is Gunjana, sir. If I think there are no more queries, we can stop it, sir.
So there were a few queries which I answered at the end of birth asphyxia. I
Yes.
think you joined later, right? When seizures
No, no,
started.
no, sir. I joined after 5 minutes of the starting of the lecture.
Okay,
Around 8:07, I joined. Yes, sir.
okay.
First.
You want to make any comments on?
No, 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 sir. Fine, sir. I think everything was covered. You have emphasized most of the points, sir.
Right. All right then. Thank you. Thank you, everyone. Bye. See you.
Okay. Thank you, sir. Good night, sir.
Good night. Good night. Thanks. Bye.